Hello guys, welcome. So I'm Dr. Alekhya taking your INI-CET short questions for orthopedics, right? So this session is mainly for people preparing for INI-CET. So here we have bought a good number of questions, mainly your PYQs, right? So we are concentrating on the previous year questions, and I have bought all the important questions in one short series, right? So let's get started with the questions. So the first question here we are looking into is, so the first question here is on your screen. So this is the image. So this is the image based question. So let's read the question. So 74-year male presented to the orthopedic OPD with a history of pain around the hip joint, and he had limp on walking, and x-ray was taken for that particular limp, and which was as shown below, right? You can see that x-ray, and then in the x-ray you can see that there is a destruction, right? You are not able to see the head, you're not able to make out the acetabulum, and they have written something for us, that is they have said that there was a reduced joint space and a haziness on the left side with the irregular opacities on the right side. So what would be the most probable diagnosis? So here what we are dealing with is the joint disorders, right? So here if you see, there is the bilateral involvement of the joint, right? You can see that two joints are involved, both the right and left side of the joints, right? And if you can make out here you can see the subchondral cyst. So these are the subchondral cyst on the x-ray, and if you see, you can't make out the head properly, and there is a lot of sclerosis, right? So there is a lot of sclerosis, and there is subchondral cyst, right? And there is a decreased joint space, so you can't make out the joint space too, right? So for any naive person to comment on this x-ray, first we would tell it could be a osteoarthritis, right? So first diagnosis will always be osteoarthritis, so which is not there in the options given below, right? So we have ankylosing spondylitis, rheumatoid arthritis, avian of head, and TB hip as options. So here if you see the sclerosis and subchondral cyst, mainly they point towards your avascular necrosis of the head. So if the patient is having avascular necrosis of the head, you can see that the head is completely worn out. So there is complete uptake of the head. So head is completely degenerated. Then the joint space is reduced, and then it will reach the acetabulum, and then it will completely result in your osteoarthritis, right? So the answer of this question will be your avascular necrosis of the head. So here it is the avascular necrosis of the head for this particular x-ray. And why it can be ankylosing spondylitis? Because in ankylosing spondylitis, what is the disorder of this ankylosing spondylitis? If you remember, the ankylosing spondylitis is nothing but this is HLA-B27, right? Associated with HLA-B27, and it is usually seen in young males, right? And the most important feature of ankylosing spondylitis is the calcification. So you see there is a huge amount of ossifications and calcifications which are occurring, and mainly this is seen in your axial spine, right? It is mainly seen in your axial spine, and here if you remember, you can see what is called as your bamboo spine, right? And your dagger sign, where there is the ossification of your ligaments. So the spine ligaments will get ossified. These are called your dagger sign, right? So that is about the ankylosing spondylitis. And if you see in this particular x-ray, in ankylosing spondylitis, you mainly see what is called as enthesis. So what is this enthesis? Enthesis is a point where the ligaments or tendons are attached to the bones, and that particular area of the bone where this attachment is seen will get calcified. So there you see some abnormality at the attachment. So this is called the enthesis. So mainly it is a disease of enthesis, and then usually in ankylosing spondylitis, it is associated with your extra-articular manifestations. So extra-articular manifestations are usually seen in spine, So these extra-articular manifestation after these whatever the calcifications or the syndesmophytes, whatever the abnormalities in spine, then you will also see the extra-articular manifestation as your uveitis, right, or any cardiac manifestations or pulmonary manifestations, right. So the person, usually the question starts with a young male adolescent, right, adolescent age with extra-articular manifestations, and usually they see the pain is mainly in the early morning. So when they wake up from the bed, they usually experience this pain in the low back area. So when a male patient presenting with low back pain and with extra-articular manifestations, and if you see the calcification on the x-ray, so it is mainly your ankylosing spondylitis, right. And then so in this particular x-ray, you don't see any features of those, right. So any in ankylosing spondylitis, there will be completely fusion of the joints. So here there is no fusion of the joints, right. So it could not be ankylosing spondylitis, right. And next, if you see this particular x-ray here, this x-ray, if you see, it is clearly a x-ray of your avascular necrosis. So clearly it is your avascular necrosis. So where you can see there is the formation of your subchondral cyst. So mainly there will be formation of subchondral cyst and there will be sclerosis of the head, right. So these two are important features to diagnose it as your avascular necrosis. And coming to osteoarthritis. So what is osteoarthritis and how do you diagnose it? So coming to the osteoarthritis, what you have to remember is there are 4 cardinal signs which you have to remember. So the first one is there is a reduction in joint space. So there will be a joint space narrowing, right. So there will be a joint space narrowing. Okay, there is a question from Pooja Chowdhury. Every patient will develop extra-articular manifestation. So the answer for this particular question is usually if you want to diagnose it as ankylosing spondylitis, the first one should be it is associated with HLA-B27, right. And then usually these present with extra-articular manifestations. So mostly 95% of the people will present with extra-articular manifestations, right. So it is majority of the patients, not every patient, but majority of the patients presents with your extra-articular manifestations in case of ankylosing spondylitis, right. So I think that I have answered. So coming to our topic here. So in osteoarthritis, what are those cardinal signs which you have to see? So first one, what you see is your joint space narrowing. So osteoarthritis is invariably associated with joint space narrowing. And then you see formation of osteophytes. So there will be formation of osteophytes and then there will be sclerosis. So this sclerosis and osteophytes with joint space narrowing put together give you an impression of osteoarthritis, right. So when it is these 3, so you have to diagnose it as osteoarthritis. And then coming to your tuberculosis. So how do you diagnose the tuberculosis? So tuberculosis, mainly what you see is a localized osteopenia. So this is the first thing which you see on the x-ray. So localized osteopenia. And then there will be demineralization of the bone. Demineralization of the bone. And mainly there is bone destruction. So in TB you see the bone destruction with osteolysis, right. So there are also feature of your joint space narrowing, but mainly what you see on TB is your destruction of the bone. So destruction of the bone will be present, and ultimately because of this demineralization with deformity, mainly they present with your subluxations and dislocations. So they mainly present with subluxations and dislocations, right. So this TB, whenever it is present in the joints, can be of various stages. So first stage is stage of synovitis, right, where there will be just an inflammation of the synovium, right. There the patient presents with some symptoms like, if it is TB hip, if you're talking about TB hip, then they present with fever, right. So the first stage is stage of synovitis, so where they present with fever. Now the synovium is inflamed and you will see the joint is full, so it will occupy the functional position where the fluid could be accumulated, right. So it will provide space for the fluid to get accumulated there. So that position is your flexion, abduction, and external rotation, that is Faber, right? So the first stage. And the second stage you will see the father. So here after the stage of your external rotation, it goes into internal rotation. So here you see there is an apparent shortening. So this is a stage of after synovitis, it will be stage of early arthritis. So now the early arthritis will set in. So now this presents as a shortening where it goes into internal rotation, right? And then there will be third stage where it is late arthritis. In late arthritis, again it is farther, right? So here it will be what is called as shortening, which is true. So what is difference between apparent and true? Apparent is false. So when you correct the position because of the tilt of the pelvis, you will feel it as shortening. But when you correct the pelvis rotations, you can see what is the correct size of the limb. So most common area in spine, med psycho, most common area in spine, or what? I am not very clear about the question. Can you please frame the question properly? So now coming to the TB here. So first is synovitis, then is early arthritis, then is late arthritis where you see through shortening, and finally the patient will enter into the fourth stage where you see there will be dislocations or subluxations. Dislocations or subluxations, and this in case of your hip, you will see the conditions such as wandering acetabulum. So now the acetabulum will become big and the femur head will move up and down. So this is wandering acetabulum. And then you will see the motor and pestle appearance. So you will see the motor and pestle appearance again where the acetabulum will become very wide and you see that the femoral head is smaller in size. Like something which you use in the kitchen, the motor and the pestle like this, right? So these are certain manifestations of the TB. So based upon this stage, again there will be changes in your X-rays. So first stage there usually will be no changes. So mainly they will be related to your osteoporosis or osteopenia, right? So there will be localized demineralization, something like that around it. And then when it comes to arthritis, you will see what is called there is a joint space decrease. There is a erosions, bony erosions will be seen, and on clinical examination you will see that the movements are restricted, right? And the third stage, the bone destruction will be evident, and in the fourth stage you can see that there is a deformity or there will be complete destruction which might be present in case of hip as a wandering acetabulum, right? In case of knee, you will see what is called as the triple dislocation of knee, right? So this is about the TB hip and TB knee. So that is about the joint disorders. So we have read about ankylosing spondylitis, then TB, and then the osteoarthritis. Now coming to the inflammatory arthritis. So in case of inflammatory arthritis, the main thing what we have to remember here is about your rheumatoid arthritis, right? So is this rheumatoid arthritis, this is an autoimmune disorder. So in autoimmune disorder, you see what is called as the antigens and antibodies. So antigens are already present in your body. So antibodies are produced there, and then these will cause the reactions in the synovium. So these antibody and antigen reactions will cause the effect in the synovium, and here they will form what is called as pannus, and this will destruct your joint, right? So this is the scenario what is seen in your rheumatoid arthritis. So here also the X-ray changes in rheumatoid mainly again will be there is a decrease in your joint space. So again there will be a joint space narrowing, and then you see what is called as bony erosions and periarticular osteopenia. So this is very important in case of your rheumatoid arthritis. So you will see what is called as periarticular osteopenia. That is around the joints you see there is a decrease in the density of the bone, and then you see bony erosions, right? And one more important thing which you have to remember in case of rheumatoid arthritis is that is it is usually bilateral and it is usually symmetrical. So bilateral, symmetrical, and these deformities are mostly seen in the case of hand. So mostly patient present with pain, swelling in the hands, and if you see all these features and they are associated again with your polyarthritis or polyarthralgia. So there is involvement of multiple joints, and especially you have to look for the involvement of your hands, and it will be bilateral. So this is about the rheumatoid arthritis. Yeah, it is RA factor. So this is RA factor, which is very positive here, and this is the antibody. RA is nothing but your antibody which is produced in the rheumatoid arthritis. And now the diagnosis of this is being shifted to the anti-CCP antibodies. So now you have to confirm it with your anti-CCP antibodies. When this test turns out to be positive, then you can declare the patient as rheumatoid arthritis, right? And now let us see a few of them of seronegative conditions. So in that seronegative, we have already finished the ankylosing spondylitis, and let's quickly discuss about your psoriasis. So in case of psoriasis, it is again a skin related conditions, and here you see what is called as oligoarthritis. And what is the important thing you have to remember is the involvement of your DIP joints. So there will be involvement of DIP in case of psoriasis. Whereas rheumatoid, what is involved? They are mainly the PIP joints and the MCP joints which are mainly involved in rheumatoid arthritis. So based upon this history, so if the MCP are involved, the PIP are involved, then you have to diagnose them as your rheumatoid. If DIP is involved with some skin conditions, so it is psoriasis, and in psoriasis it is usually oligoarthritis, right? So only small amount of joints, only minimum amount of joints are involved, and in that the DIP is the main thing. And here you see pencil in cup appearance in the X-ray. So the X-ray finding of psoriasis is the pencil in cup. And usually the psoriasis arthritis are very destructive, and hence they are also given a term which is called as arthritis mutilans, right? Arthritis mutilans. So this is about your psoriatic arthritis. Okay, so these are some of the joint disorders, and one more important thing which I want to cover here is about your gout. So as you already know, there is one more important condition which is called as gout, and this is a crystalline deposition disorder. So in crystalline deposition, because of increase in the uric acid, so this is because of hyperuric acid levels, and this uric acid gets deposited in the joint, and this will produce what is called as gout. And mainly this gout is seen as podagra. What is podagra? It is the first MTP which is involved. So here regarding the gout, it is the first MTP which is involved, and here you see the increased serum uric acid levels, right? So and this acid can be this uric acid crystals which are deposited in the joint. They can be taken from the joint aspiration, and they are seen under polarized light where they are negatively bifringent, right? They are negatively bifringent. So this is about your gout. And these are some of the joint disorders. So starting from osteoarthritis, rheumatoid arthritis, psoriatic, and crystalline deposition arthritis. So these are all the joint disorders which you have to quickly memorize when you get a question from the joint disorders, right? So that's it for the first question. Yeah, in psoriasis, you can see the arthritis can also be associated with the nails. Yeah, nail changes are seen in case of psoriasis, right? Now the second question. So this is about the dislocation of hip. So in this, let's find out the statements here, and let's tell which is the false one, right? So all the following statements are true except is the question. So in this, the posterior dislocation of hip is more common than the anterior dislocation. Yes, the posterior dislocation is more common, correct. And then the vascular injury will be more common in the anterior hip dislocation. Yes, let this question be at side. And next we'll see the third one. Nerve injury will be more common in the anterior dislocation of hip. And the fourth one is in posterior hip dislocation, the attitude of the limb will be adduction, flexion, and internal rotation. So this is correct. So it will go into flexion, adduction, and internal rotation in case of posterior dislocation of hip. So we are sure that the A and D are correct. And let's see the C option. So nerve injury in case of anterior is not very common, right? So when nerve is not common, so this answer is, in case of posterior dislocation, there will be an injury to the nerve, and this is very common nerve injury. And what is this nerve which is most commonly involved? Quickly. So this is your sciatic nerve, which is involved in case of your posterior dislocation of hip. So whenever there is a dislocation of hip onto the posterior aspect, there will be sciatic nerve which will get injured, and the patient presents with your sciatic nerve palsy. And now coming to this, usually the vascular injury is not very common, and in case of anterior hip dislocation, this is also a correct statement. So sometimes this could be, the vascular injury can be seen in anterior hip dislocation, but compared to the C and B, I feel C is the most incorrect one. So the answer here would be C, and vascular injury is seen in case of anterior dislocations, right? So this is the answer for this. And now let's quickly revise about the dislocation of hip, and this is one of the most important topic, and usually it is frequently asked in the examinations. So let's see, if now I have placed all the 3 x-rays in front of you. So the first one is the A, second one is the B, and third one is the C. So A here is your posterior dislocation, right? And B is your anterior dislocation, and C is your central dislocation. So let's quickly revise what are those important points in posterior dislocations. So you see the posterior dislocation, it is the most common type of hip dislocations. So to that to that point, what is the most common dislocation of all the joints? So the most common dislocation of all the joints is your, yes, it is your shoulder joint. But in case of hip, the most common is your posterior dislocation. So posterior dislocation is supposed to be the most common type in all the 3, among all the 3. And then, so in the posterior dislocation, whenever the hip is dislocated posteriorly, the patient will present with a peculiar attitude which is called as flexion, adduction, and internal rotation. So based upon this particular attitude in the emergency room, you can come to a conclusion of hip dislocation. And now on the x-ray, you see the internal rotations where you can't see your lesser trochanter. So for this, if you take this x-ray, and this is your normal side and this is your dislocated hip, and if you see the Shenton's line, and here this is your lesser trochanter. So whenever this is rotated internally, you can't see the lesser trochanter, and there is a break in the Shenton's line, so there is a proximal migration, and all this favor the attitude of flexion, adduction, internal rotation, and will tell you that the head is dislocated posteriorly, right? And so here, this is the attitude which you see in case of your posterior dislocation. And coming to the anterior dislocation, what the attitude which you see? So the attitude which we see in anterior dislocation is your Faber. Faber is flexion, abduction, and external rotation. So if you see here, what I've told you previously, the lesser trochanter is more prominently seen. So whenever you external rotate, you will see the lesser trochanter as a prominent thing on the X-ray film. So this is your anterior dislocation, right? And here the central dislocation. So here the central dislocation is almost always associated with the pelvic fracture, right, or the acetabulum fracture. So it is always a fracture dislocation, and inevitably it will go to osteoarthritis. So why are we very much worried about the dislocations? So whenever there is a dislocation of the joint because of this movement of particular part of the joint, so in this case the femoral head is going out of the acetabulum, so this will cause a stretch over the vessels, stretch over the nerves, hence there will be a vascular injury which is common, or the nerve injury which is common. But we have already seen that in case of this, the nerve injury is very common, which is the sciatic nerve. right? So sciatic nerve injury is most common here, right? And you can see there is a swelling which is present on the gluteal region. If the patient is a thin individual, you can feel there is a bony swelling round in shape which is present on the posterior aspect. And here the vascular sign of Narath, which you feel over the femoral head, is usually positive. That means it is absent. The vascular sign of Narath is positive. That is, the pulses cannot be felt. So these are some of the features of your posterior dislocation. And what is the immediate treatment of this? So dislocations are always an emergency, and if not reduced, they will result to a condition which is called as your avascular necrosis, because the head is compromised with the blood supply. So you have to reduce it immediately. So always you have to, reduction is the main thing which you have to do, and it is again the open or the closed. But when it is a simple dislocation not associated with the fracture, you can always go with a closed reduction. So always try for a closed reduction. But in case of your hip joints, usually we do this under the effect of the anesthesia. So you anesthetize the patient and then you reduce it. How do you reduce it? You put the patient in supine position on the floor, and then you flex the knee and the hip, and then what you give is the longitudinal traction. So you have to pull the femur up and then slightly do the rotations. Then your head will come and sit into your acetabulum. There you can hear what is called the click sound, and then you put this limb in external rotation. So again you put this limb in external rotation, that is with your traction, for at least 3 weeks. So this is the treatment. So when it is closed reduction, so when you're doing a closed reduction and the reduction is satisfied, and if there is no re-dislocation with the reduction, then you go for what is called as traction for 3 weeks, right? And if the reduction is not satisfied, or if it is redislocating, again you have to always go for open reduction and check for any other fractures on the X-ray or the CT scan. So that is the treatment for your posterior dislocation of hip, right? And central dislocation is inevitably always associated with what is called as your fracture dislocation. So usually we go for an open reduction, and you have to reconstruct the acetabulum based upon the X-ray and the CT scan. And acetabulum felt in gluteal region on palpation in central dislocation? No, in central dislocation what you see is the head which is seen as perrectal. So you do what is called as a perrectum examination on, and PR you can feel the head. That is only in case of your central dislocation, right? And dashboard injuries. Yeah, the most common mechanism of injury in case of your posterior dislocation is your dashboard injury. So Mohit, as you got this up, let us discuss little about this dashboard injuries. So that is in case of dashboard injuries. So whenever you are driving a car sitting in a flexed position, so based upon the position of your limb during the injury, also that decides your fracture. So if you're sitting in flexion and flexion position, it will go into your posterior dislocation. So a dashboard is nothing but there will be flexion of the knee, and here the whatever the dashboard in the car will gets hit into the knee, which is in flexion position, and simultaneously the hip is also in flexion position. So here you see 3 important injuries in the dashboard. The first one is your posterior dislocation of hip, and the second one is your patella. So because the direct injury, there will be patella fracture, and particularly in this type of injury there will be what is called as the comminuted fracture of the patella. So based upon the comminuted fracture of the patella, you can even evaluate the patient that this might be a case of dislocation too. So based upon the mechanism of the injury. And the third and the important thing which you have to remember in dashboard injury is your PCL injury. So there will be a injury to your posterior cruciate ligament in the knee joint. So if you remember, there are 2 cruciates, the anterior and the posterior. So here in this case of your dashboard injury, the posterior cruciate ligament is at risk. So you have to even evaluate for the posterior cruciate ligaments, right? Yeah, in PR, in the per rectal examination, you will feel the head. You will feel the head in case of central dislocation, only in case of central dislocation, right? So that is about your dashboard injuries and your posterior dislocation of hip, right? So complications you have already dealt with, the sciatic nerve injury, right? And they will be in case of your anterior dislocation, your femoral artery, that is the vessel injury which can happen. So I think this question will be a cakewalk for you. After discussing so much about the posterior dislocation, what would be the attitude of the limb? So now the attitude of the limb here is, what is this? Adduction and internal rotation. So this is the attitude, the adduction and the internal rotation. So mainly flexion, adduction and the internal rotation is seen in case of posterior dislocation. So that is the take home message. And in case of your IC fracture, it is your flexion, abduction and your external rotation, right? And even in your IT fracture, this is the same. So these are few important things, basic things which you have to remember. K wire in comminuted. Okay, in case of patella fracture, so in case of patella fracture, K wires, they don't work in case of comminuted fractures. Where do you put? You cannot put all fragments and put a K wire into it. It is very difficult. K wires or the tension band wiring is only done in case of your transverse fractures of the patella, right? In comminuted fractures, we have to decide to whether you have to do for a patellectomy where you can remove all the fragments. So that depends upon the amount of comminution which is there in the patella fracture. So that completes our questions, and then we are going to the fourth question. So this is about your tumor, right? So here the patient was found to have a lesion at the tibial diaphysis with the reaction that were visible on the bone surface. What would be the most probable diagnosis? I think this is a very not very informative question, but I think you're all smart by seeing this diaphysis in the tibia, and you see some reactions, that is might be the periosteal reactions which we were talking about. So the x-rays, so the most probable diagnosis here would be, yes, the Ewing's sarcoma. So coming to the tumors part, I'm very happy that you have answered these questions very right. But let us discuss few important topics from the tumor topic, right? So that we can answer any question that comes from the tumor. Right. So the first one, you have to always remember that in case of tumors, you have to segregate them based upon their cell of origin. So few cells are, osteoid forming, and then cartilage forming, and then you see what is called as a giant cell rich, right? And then you see something like the tumor like conditions and hematological, right? And then you have neuroectodermal tumors. So these are some of this based upon your origin of the cell. So here what I want you to remember is that is whenever they say there is an osteoid forming on the x-ray, you have to remember these three things, right? So these three tumors. So first is your osteosarcoma, right? And then your so this is your malignant type, right? Your osteosarcoma is the malignant type, and next comes your osteoid osteoma, which is a benign type, and you have one more important thing, the osteoblastoma. So here when I say this is blastoma, this is the intermediate type. These intermediate type are supposed to be the notorious one. So yeah, it is simple, right? The answer of the diaphysis in Ewing's is simple. Very good. So now let us just get a brief of all the tumors. So that I will make it this very simple for you. So whenever you see an x-ray or you see a question regarding the tumors, first decide from which cell is this tumor coming from. So whenever they say there is a bone formation or a calcification which you see, this could be a osteoid formation, right? So there is an excessive bone which is seen on the x-ray. So when it is a malignant tumor, so this is osteosarcoma, and if it is an intermediate, it is osteoblastoma, and it is a benign, it is osteoid osteoma. And then cartilage, similarly you have chondroblastoma and chondrosarcoma. Chondroblastoma is the intermediate, and you have the chondrosarcoma, which is the malignant. And here the important one is the benign part of this is your osteochondroma. Right, and then the giant cell ridge. The giant cell ridge, you all know, that is your giant cell tumor. So giant cell tumor is your giant cell ridge, right? And then tumor like condition are your cyst. So we have simple bone cyst, you have aneurysmal bone cyst, right? And hematological, this is most important. The most common bone tumor is multiple myeloma. So most common tumor which you see in case of orthopedic oncology is multiple myeloma, and when it comes to neuroectodermal tumor, it is your Ewing's sarcoma. So this, why I'm telling this as important thing is this could be a area where they can integrate the questions with the pathology and can ask you regarding this particular tumors, right? So on the HP, that on the biopsy, if you see there is an osteoid formation, then you can tell these three tumors, such as your osteosarcoma, or osteoid osteoma, or osteoblastoma, can be a differential diagnosis for it. If you see a giant cells on the histopathological slide, it is giant cell ridge tumor, that is the osteoclastoma. So osteoclastoma is one particular type, which is the giant cell ridge variety. And there are tumor like conditions such as your aneurysmal bone cyst, your simple bone cyst, right, your fibrous dysplasia. So these are certain conditions which mimic like the tumor. And from the hematology, you have the multiple myeloma, which is considered as the most common condition in orthopedic oncology. And now coming to your neuroectodermal tumor, it is the Ewing's sarcoma. Once you have understood from which cell is the tumor coming from, then you have to decide the location. Based upon the location of the tumor, you can again conclude. So if you remember the long bone, which can be divided into epiphysis and the diaphysis and the metaphysis. So here again the metaphysis is considered to be the most important area, and this is, if you remember, again it is seen as important with the infections. So the infections and the tumors most commonly occurred in the metaphyseal region. Then what here the epiphysis, if you see, there are only two important conditions which you have to remember in the epiphysis. So first one is your giant cell tumor or the osteoclastoma. So giant cell tumor or the osteoclastoma is the main thing which you have to remember, that is the epiphyseal location. So in the long bone, if you see a tumor which is in the epiphysis, it could be a giant cell tumor, or the second one is your chondroblastoma. So these two tumors are mainly seen in your epiphyseal region. Then coming to the diaphysis, you have already answered one, that is your Ewing's sarcoma. So after Ewing's sarcoma, there is one more, that is your osteoid osteoma, right? So osteoid osteoma, the Ewing's sarcoma, these are mainly seen in your diaphysis. And there is fibrous dysplasia, and then you have your adamentinoma. So these are all conditions which are seen in the diaphysis. So once you see the X-ray and if you see that there is a tumor in the diaphysis, these are the common simple things which you have to get into your mind so that you can answer them in an easy way. Then the metaphysis. So metaphysis, the most important thing is your osteosarcoma, osteochondroma, and then your enchondroma, right, and then your simple bone cyst, your aneurysmal bone cyst. So, and one more miscellaneous one is your non-ossifying fibroma. So these are certain things which you see in the metaphyseal region, and in that the most important thing which you have to remember is your osteosarcoma. So this is the metaphyseal origin, and then is your osteochondroma. This is the most common benign condition again in whole orthopedic oncological part. So in oncology, that is the tumorous condition, the most common benign condition which you see is your osteochondroma, right? And this is seen in your metaphyseal region. And most common malignant bone tumor which is non-hematopoietic, that is other than your multiple myeloma, the most common malignant tumor is considered as your osteosarcoma. osteosarcoma. So these are certain important things which you can remember. Yeah, you can also, yeah, diaphysis is osteoma, correct. So these are certain things which you can remember, and you can deduce from the question. And one more thing, so once you are aware of the cell of origin and the location, then you have to look for the periosteal reaction. So there are certain important periosteal reaction for certain specific tumors, and based upon these periosteal reactions you can answer which tumor does it belongs to. So let's make a quick answer to this table. So here the first one is your Codman's or the sundry appearance. It is the most easiest one, that is your osteosarcoma. So these are supposed to be the simple one-liners, or it can be integrated with your radiological questions, right? So they can be integrated with the radiology, or they can be asked as a simple one-liners. So just have a look at this table. So the first one is your Codman's or sundry appearance. So sundry appearance, again, because of the calcifications which occur around the tumor, that along your Sharpie's fiber or along your vessels. So this is considered as a sun ray appearance, usually seen in case of your osteosarcoma. Then your onion peel appearance is your Ewing's sarcoma. Again, this is a type of periosteal reaction in case of lines. So you see something which is related to like your laminated appearance of the onion. So hence it is called as onion peel appearance. It's commonly seen in your Ewing's sarcoma. Next, most very important is your soap bubble appearance, and this soap bubble appearance is very specific for the osteoclastoma or the giant cell tumor. Both are same. It is called as giant cell tumor or the osteoclastoma. Then comes the important one recently asked in the NEET PG, right? So this is your Shepherd-Crook deformity, which is seen in the fibrous dysplasia. So in fibrous dysplasia, whatever the bone part is replaced by the fibrous tissue, hence this also looks like what is called as the ground glass appearance. And because of the fibrous tissue is very not very strong as bone, hence it gets into deformed positions, and this deformity is nothing but your Shepherd-Crook deformity, right? So Shepherd-Crook deformity is seen in your fibrous dysplasia, right? And then you can see the fallen leaf fragment. This is seen in the simple bone cyst where it is associated with a fracture. That is called the pathological fracture. So whenever there is a simple bone cyst with the pathological fracture, you see what is called as a fallen leaf fragment. Then the winking oval sign in the vertebral metastasis. So you can see the vertebral body has two pedicles, right? So if the pedicle are seen clearly, it is usually the normal thing, and if the pedicle is involved, you see what is called a winking oval sign, which is seen in case of metastasis. You can see the metastasis, and here in the tumor you have to remember what is most common condition where the patient present with is the secondaries. So in bone usually we see the secondaries then primaries. So when it is primary, then the most common would be your multiple myeloma, but among everything, what is the most common is your secondaries. So in that case again in the secondaries, the most common is seen in your vertebrae, that is the thoracic vertebrae. So in that you see what is called the vertebral metastasis, that is the winking oval sign. And homogeneous calcification, just put a catch here, when it is an homogeneous, it is osteosarcoma, and when it is your popcorn calcification or a comma shaped calcification, which is seen as punctate calcification, that is in case of your chondrosarcoma more than your chondroblastoma, right? So when it is punctate type or spiculated calcification, popcorn calcification, then you have to answer it as a cartilage forming tumor such as your chondrosarcoma or chondroblastoma. If it is a homogeneous calcification, it is usually seen in case of osteosarcoma, right? And moth-eaten appearance, it is multiple myeloma. So multiple myeloma usually seen are punched out lesions on the skull or moth-eaten appearance, aggressive, so it is multiple myeloma. Then polka dot or quadri appearance, this is hemangioma, and this is mainly seen in the CT scan as this polka dot or your corduroy pant or the cloth which is seen as a striated line. So these are the corduroy appearance or the polka dot appearance that is seen in case of your hemangioma. So these are certain important periosteal reactions which you have to remember, and this play an important role for taking you to the diagnosis, right? So that completes the tumor part. Next, coming to the fifth question. So hope you are all following. Now coming to the Pott spine, what would be the most common pattern of the involvement? So this is one of the very simple question, very easy and a straightforward question. There is no much to think about it. And if you remember the Pott spine, that is tuberculosis. First you have to know the Pott spine is nothing but your tuberculosis of spine is called as Pott spine. And in that case, the most common would be a paradiscal. Right? If you remember, this is the vertebral body, and here you see the disc above and below, right? And usually the tuberculosis is seen, this is the tuberculosis which is seen in and around the disc. So usually the disc is involved in case of tuberculosis, and the most common pattern would be the paradiscal part. And when it comes to the TB, so it is called the Pott spine, the tuberculosis, TB spine, right? And this is the most common part which is involved in case of tuberculosis, that is the spine, right? So spine is the most common part, and the second is your TB hip, and third being your TB knee. So this is how the TB presents with you, and it is mainly in the dorsal lumbar region that is more common. So dorsal lumbar region, then it is the thoracic, and then it is your lumbar. So this is how the TB is most common in spine, and in that spine again it is the dorsolalumbar area, followed by thoracic and followed by your lumbar. And second most common area where you can see tuberculosis is your tuberculosis hip, and third is your TB knee, right? And we have already discussed a little bit of TB hip, where we have discussed about various stages which it goes through: the synovitis, the early arthritis and the late arthritis. Early arthritis and the late arthritis. And now in case of spine, you see that there is the involvement of paradiscal position, that is the area which is above and below the disc, so that is involved. And what is anterior and the posterior and the central, let us see. So when you, this is your vertebra, right? And let us see, this is your disc part. And if the TB is there on the anterior aspect, it is usually present as the cold abscess. So this cold abscess here will pass along your anterior longitudinal ligament which is present on the anterior aspect, and hence this TB, this tuberculosis is called as your anterior type. Right? So whenever you see on MRI that there is a fluid collection over the anterior aspect, or the anterior ALL is being involved, the anterior part of the vertebrae is involved, then it is the anterior type. And now coming to the central type. So in case of central, it is the center of the vertebra, right? So this is the central. This is the central type. And then posterior is the posterior elements which is involved. So posterior elements is your spinous process, your pedicles, your transverse process, and all this gets involved. So whenever it is involving the posterior elements, it is called the posterior, and this is the central part. And the most common, which I've already discussed, is your paradiscal position. Paradiscal, where the disc is involved. So you will see on the X-ray that the disc is involved. There is a joint space, I mean the intervertebral disc space is narrowed, right? So there is a disc space narrowing which is seen in case of tuberculosis, and there will be a reduction in height. Again, if you remember, in TB there will be destruction, so bone destruction will be there, where there will be loss in the height of the vertebra. And with the disc space narrowing and with the presence of cold abscess, so there will be abscess or the calcifications which you can see over the X-ray, and this is important for diagnosis of your tuberculosis. So these are the important salient features which you would see on the X-ray in case of tuberculosis. And usually TB, it can be treated and it is treated with the anti-tuberculous drug. And what is the main thing? Patient presents with your night pains and patient present with your low back pain, night time very severe, with the constitutional symptom of loss of weight and the loss of appetite. So these two are the very important constitutional symptoms which you have to remember with the evening rise of temperature, right? And in case of bone and joint tuberculosis, this temperature is not very much seen, but loss of weight and loss of your appetite is one of the salient constitutional symptoms which we see in case of tuberculous patient, right? And this Pott spine or TB spine can be produced with the paraplegia, right? So TB spine with paraplegia, that is the weakness of the limbs. So weakness of the limbs, and here you can see early onset and the late onset of paraplegia, right, depending upon the condition. So early onset is usually because of the inflammatory process which is occurring there. So we have already discussed that the inflammation in case of your necrosis of the bone, and there will be formation of the abscess. So this will cause some amount of irritation over the nerves, some amount of granulation tissue formation, and hence it will result in paraplegia. In case of late onset, it is mainly because of the mechanical things, that is because of the stenosis which is occurring and because of the pressure putting upon the nerves, and this will result in the paraplegia, right? So this is early onset and late onset, and usually in case of non-paraplegia or paraplegia, you can still go for conservative treatment, and this is called what is called as the middle path regime. So this is the middle path regime which is followed for tuberculosis of spine, where the patient is given adequate rest and brace, that is for the support of the spine, and then adequate treatment such as your nutrition and proper care to the patient. So that is the middle path regime, and here are certain red flag signs which you have to observe. These red flag signs will go for what is called as the surgical fixation, right? So there are certain procedures which you do for the TB. So whenever there is a formation of your abscess, so if the abscess collection is very big, or if you want to remove that, you go for drainage of that abscess, or still you can follow with your middle path regime, right? So in case of red flag signs, so if the onset of the paraplegia, if the paraplegia is progressive, right, if it is, there is the involvement of your bowel and bladder, and there are certain red flag signs which you have to look for. So the first one, important one, is the progression of your paraplegia, or if there is involvement of your bowel and bladder, if there is a sudden onset of paraplegia, and if the patient is not recovering with the middle path regime, then all these conditions will take you to the surgical fixation. So there you can do costotransversectomy, where you remove a part of the vertebrae, part of the transverse process, so that you drain the abscess which is present here, so that abscess which is causing the pressure over the nerves, so that is resulting in paraplegia. So you do this costotransversectomy and you remove the whatever the abscess or the collection which is present there, you drain this collection, and hence you can treat the patient with the treatment called as your costotransversectomy. So that will reveal the patient's pain and the paraplegia will recover. So this is about your Pott spine, and I don't think that I have to tell you about the most important person, that is the Mycobacterium tuberculosis is the drug, and this can be an integrated question with the microbiology, where the presence of mycolic acid in the cell wall of the Mycobacterium tuberculosis makes it so special, and this is stained by Zn staining, that is called the Ziehl-Neelsen staining. And usually now we are going for what is called PCR test for diagnosing of this tuberculosis, right? So this is about the Pott spine, right? And the brace which we use is your Taylor's brace. So the brace which we use is your Taylor's brace for the rest of the part, plus your ATT is the treatment. So that is about the Pott spine. So coming to the next question, which of the following nerves will supply the marked structure in the image given below? Right. So this particular muscle which is marked here is the lumbricals. So this is the first lumbrical which you are seeing here, and if you remember, the first lumbrical is supplied by your median nerve. Yes, the median nerve is the one which supplies your first lumbrical. So let us see some important aspects for the peripheral nerve injuries. So coming to the peripheral nerve injuries, so what you have to remember here is there are three important nerves which you have to remember. So that is your first one is your radial nerve, then comes your ulnar nerve, and then your median nerve. So these three are the important nerves which you have to remember, and there are certain important tests which are associated with it. Before learning of this test, we have to see what are the muscles with which it is supplied with. Right. So now, so what is the radial nerve which is associated with? So radial nerve supplies which important muscles? So I am waiting for the answers. So radial nerve will supply all the extensors. It supplies all the extensors of the hand, the forearm, and the arm. So the upper limb completely is supplied by your radial nerve. So the extensors of your hand, forearm, and arm, all the extensors are supplied by your radial nerve. Now coming to your ulnar nerve. Ulnar nerve supplies. Ulnar nerve is called the musician's nerve. So it is mainly important for supplying of your intrinsic muscles of hand. So what are the intrinsic muscles of the hand? If you remember, first one is your hypothenar muscles which is supplied, and then comes your third and fourth lumbricals, and then your palmar and the dorsal interosseous. Right. So these are the muscles which are supplied by your ulnar nerve. Right. And here the median nerve supplies. So all the flexors except the flexor carpi ulnaris. So these are the exceptions. Your flexor carpi ulnaris and your medial half of your flexor digitorum profundus. So these two are again supplied by your ulnar nerve. These two flexors are the long flexors which are supplied by the ulnar nerve. Rest all the flexors are supplied by the median nerve, and with the intrinsic muscle, that is your thenar group of muscles and your first and second lumbricals. So first and second lumbricals with your thenar group of muscles, these are supplied by your median nerve, which is supplied by your median nerve, right? So here what is the important thing which you have to remember is the adductor pollicis. So adductor pollicis is the thenar muscle. So this is the thenar group of muscle, but this is supplied by your ulnar nerve. So adductor pollicis is the one particular muscle which is supplied by your ulnar nerve. So this you have to remember. So this is the important slide for your peripheral nerve injuries, where you can remember the extensors are by the radial nerve, all the flexors except two, that are flexor carpi ulnaris and the medial half of the flexor digitorum profundus by your median nerve. And then coming to the ulnar nerve, it is called the musician. So the movement of your hands, the playing piano or playing your veena or whatever the movements of the hand is by the finest movements is by your ulnar nerve, right? So in this ulnar nerve, the main thing where they supply the intrinsic muscles. So all these intrinsic muscles, the palmar interosseous, the dorsal interosseous, and your third and fourth lumbricals with your hypothenar plus your adductor pollicis is by your ulnar nerve. Right. So this is your peripheral nerve injuries, and here let us just remember few other nerves such as your brachial plexus. So brachial plexus, why you have to remember, there are two important things. One is your Erb's palsy and the second one is your Klumpke's palsy. So these two are the important palsies which you have to remember. Erb's palsy is mainly the Erb's point or the upper trunk which is damaged, and if you remember, there is a policeman tip deformity which is seen here. So what is this deformity? There will be a shoulder adduction and internal rotation, plus your elbow extension and pronation, right? So elbow is extended and pronated. So classically your policeman tip deformity, where the waiters or the policeman collect the tip or bribes in that particular position. So that is your Erb's palsy. Coming to the clump case palsy is the lower trunk, the C8 and T1. Sometimes it is associated with the Horner's syndrome. So when I say C8 and T1, it is again your hand. So hand, that is there will be a problem in the abduction and adduction, and your long flexors will be at the palsy. So this is your clump case palsy, and Erb's palsy is your upper trunk, and these are the deformities which you see, right? And next, coming to the next one, which is important, is your axillary nerve. So axillary nerve will supply, what is the important one which it supplies is the deltoid muscle with the teres minor. So deltoid muscle with the teres minor is supplied by the axillary nerve, and there will be a sensation, that is the sensory loss. Sensory loss is over the regimental badge area. So there will be the regimental badge area. So that is the area which is seen over your insertion of the deltoid. So exactly here, where usually, if you remember, during your childhood they would have given you the BCG vaccination. So exactly at that particular area where the army people put their badges over this particular area is for your axillary nerve, and there will be a decreased sensation of this particular area in case of your axillary nerve palsy, and there will be deficiency of abduction because of the deltoid palsy, right? So that is the axillary nerve. And then you have your long thoracic nerve of Bell, where it supplies the serratus anterior, and there is palsy of the serratus anterior will result in winging of scapula. And one more important thing is your spinal accessory nerve. In case of your spinal accessory nerve, what damage you will have? So you will be seen with the absence of your shrugging of the shoulders, right? The shrugging of the shoulders will be lost. That is the spinal accessory nerves which supplies your trapezius muscle and your sternocleidomastoid muscle. So spinal accessory supplies these two, and whenever there is a damage to this, the shrugging of the shoulders is lost. So these are some of the important nerve palsies which you have to remember. So the long thoracic nerve of Bell, your deltoid with the axillary, and your brachial plexus, right? So now coming to the next question. So that completes the a little bit of your peripheral nerve injuries. And then, which among the following would be the correct order of the stability of the fixation in case of a 3A compound fracture? So let us tell the correct order. So in case of this question, so this is mainly in a case of compound fracture. So compound fracture is that fracture where the fracture is exposed to the external environment, right? So whenever there is an exposure of the fracture site to the external environment, this is called as a compound fracture. So in this compound fracture, usually we treat with the external fixator. Why? Because whenever we put a plate or internal fixation is done, it will again act as a medium for the bacteria to propagate over it, right? So it will again lead to infection. So infection should be always avoided in case of bone. So that is why these compound fractures are usually treated with the external fixators. So what are the various external fixators? So the external fixators are mainly in the case with rods and pins. So there are two types. There are uniplanar, they could be a biplanar, or they could be a multiplanar. So this is in case of rods and pins. So there is one more type which is the ring external fixation, and this is called as the Ilizarov external fixation. Ilizarov external fixation, right? So these are the types of external fixation which you have to remember. So mainly there are two types, the rod one and the rings one. So when we say the rod or the pins, it is tube type, or you can also call it as a tube external fixator, and this can be applied in a uniplanar fashion or a biplanar fashion or a multiplanar fashion, right? So based upon that, the stability added to that fracture pattern will depend upon your fixation. So if you fix with one rod, usually the stability will be the least, and this stability can be increased if you increase the rod. So this is the next best option, right? And if you increase the stability in multiplanar fashion, so if you're giving it 3D fixation, so that is biplanar frame, again it will increase the stability. And ultimately if you give a 360 degrees fixation, so you're fixing it around the bone, which increases its stability to multiple times. So this is the fourth one. So that is the so increasing stability, in case of increasing order of the stability, the first one will be a uniplanar with one rod. Now the stability can be increased by increasing the rods, right? So if you place the two rods, then the stability will increase. And if you fix this in two planes, the stability will further increase, right? And if you fix 360 degrees, that is your X fix, it will further increase. So these are some of the examples here. So in these examples, you see this is the uniplanar fixation with a single rod. So this is your single rod. So this is your rod and these are your pins. So this is the uniplanar fixation, and here you are placing the pins. So these are near to the fracture and these are away from the fracture. So right. So how much ever near you can, if you put, then that will increase the stability. And next two should be a farther position. More farther, it will be more stability, right? And if you increase the rods, then again there will be increase in the stability, right? So this is about the fixation of the X fix. And now coming to the second type here this is called as the bridging fixation. So there is this knee joint, so the proximal tibia fracture is there and you're fixing it with the femur and the tibia. So this is the bridging type of X fix. So this is the bridging type of X fix where you usually use for the joint fixations such as proximal tibia. And here this is a 360 degrees, that is your Ilizarov ring fixation. So in case of Ilizarov ring fixation, you can see these ring type, right? So these are the rings and these are the connecting rods, right? So these are the connecting rods and you give the stability round about the fracture. So here in case of Ilizarov fixation, the principle and the treatment is mainly used in case of your non-unions and in case of your chronic osteomyelitis. So these two are the areas where usually the Ilizarov ring fixation is used, because even though it gives your 360 degrees phase fixation, it is usually cumbersome, not well tolerated with the patients, right? So usually they are reserved for a very complex fracture and non-unions, very chronic non-unions and your chronic osteomyelitis. And sometimes they can be used also for your deformity corrections. They can also be used for your deformity corrections. So this is the various conditions where this Ilizarov is used. And the principle of the Ilizarov is distraction osteogenesis. So this is distraction osteogenesis. That means there is some amount of distraction which occurs at the fracture site, and this distraction is controlled distraction and which will stimulate the osteogenesis. So there will be formation of the bone with this distraction. So hence it is called a distraction osteogenesis. So this is the principle underlying the Ilizarov fixation. And the Ilizarov has gained its popularity with limb lengthening procedures. So this was the revolution. So limb lengthening procedures was done with the help of Ilizarov, and this is mainly used for limb lengthening procedures, and now they are also being using for your non-unions and your chronic osteomyelitis and your deformity correction, mainly the congenital deformities, right? And coming to your X-fix, these two are mainly used in case of your open injuries, and they are only a temporary setup for the fracture. So once this infection has settled down, once the soft tissue and the skin over the wound is suitable for fixation, internal fixation, then you go for internal fixation. So usually when you put the X-fix, you wait for 3 weeks and then remove the X-fix, and then you do a related test for looking for the condition, general condition of the patient, the load, the bacteria, and then you confirm it, and then you go for what is called as your internal fixation, right? So that is about the X-fix. Coming to the next question. Here again, this is one more treatment part. So here the patient was diagnosed to have a fracture, of the femoral shaft, right? So femoral shaft, so here you are trying to put a skeletal traction. So as an intern, if somebody has completed their internship, and this would be one of the most excited procedure to do in orthopedics, right? So putting skeletal traction, and which among the following you are in need for doing this particular procedure, right? So let us see what are those things which you need of. So if somebody answers, that would be great. So here what are the things which are there for you are the Wallah stirrup, the Steeman pin, the Dunham's, the Bowler's frame, the Thomas splint, and the K-wide. So what are the things which you require to put a skeletal traction in case of femoral shaft? So first, if you see the femoral shaft fracture, so you go for your upper tibial skeletal traction, right? The proximal tibial or upper tibial skeletal traction, which is the most common one which is done in the practice, right? So usually femoral shaft are treated with your upper pin tibial tractions. So here, so first pin traction, you need one pin. So it could be a Steeman pin, it could be a Dunham's pin. So if the patient is a young patient, you go for Steeman's pin. So let's select the Steeman's pin, and then you need a stirrup, right? And then you need a Bowler's frame. So usually these three are ones which are required, right? Bowler's stirrup or Steeman pin or Dunham's, or if you're going for older, you go for a Dunham's pin. So it could be 1, 3 and 4. So Dunham's pin, stirrup, and your Bowler's frame. So these are the things which we usually use for putting the skeletal traction. So how do you put the skeletal traction? So this is the skeletal traction, and here if you see, this is your pin. So this could be of two types, the Steeman's pin or the Dunham's pin. So Dunham's pin is usually used in case of osteoporotic bones, and Steeman pin is used for your young patients or good bone stock, right? So these two are the pins which we are using for putting the skeletal traction, and then you use your stirrup to connect this pin to the weight, and now you add the weight. This is your Bowler's frame. So this is your Bowler's frame, or called the BB splint. BB splint, where you rest the patient, where you rest the leg over the this splint, and then you add this weight, and this weight will pull the femur fracture into alignment, right? So this is your skeletal traction. So this is your skeletal traction. So what are the areas where you go for skeletal traction? So we have already learned that is your upper tibia, and you can go for your distal femur, and you can go for your distal tibia, right? And then you can go for your calcaneum. So right, these are certain areas in the lower limb where you go for the skeletal traction. So there is distal femur, proximal tibia, distal tibia, and then your calcaneum where you go for your skeletal tractions. So this is the setup which you require. So first is the BB splint, where you rest the leg, and then you connect the weight to the particular limb, right? So this one is the Steeman's pin. So this is your Steeman's pin, which is very plain. So there are no threads. So this is just Steeman's pin. So if it's a Durham's pin, then this will have threads in the center like this. So these threads will hold the bone in case of your low bone stock. So if there is no bone stock, and if you want to hold the pin into the bone, so these threads will help you. So those are called the Dunham's pin, and this is the stirrup. So this is the stirrup, where you put the pin like this, connect the pin to it, and then you add weight to it. So this is where you add the weight to it, and then the pin is connected. This is your skeletal traction, right? And now coming to the next question, and skeletal traction is again done in cases where you have to wait for the patient to take to the internal fixation. So it could be a patient who is not fit for the surgery, or if you need some time, or if you want to align the fracture immediately to reduce the pain, so then you go for this skeletal tractions, right? So that are the various situations where you go for your skeletal tractions. Now let us see the next question. So that organize the steps involved in the Thomas test test in the correct order. So here we are dealing about the Thomas test. So first you have to remember that the Thomas test is mainly used for assessing what? It is used for assessing your fixed flexion deformity of hip joint, right? So this was given by the Thomas, so hence it is called as Thomas test, the fixed flexion deformity of the hip joint. So how do you do this? So here what you have to remember is there will be deformities in the hip joint based upon the pathology. So whenever there is an AVN or osteoarthritis happening in the joint, there will be the pull of the muscles, and now this there will be loss of the extension in the particular hip joint. So first there will be loss of extension, which is called as your flexion deformity. So flexion deformity, so this is not fixed, just a flexion deformity. So what is a flexion deformity? Flexion deformity is nothing but there will be loss of extension. So the patient cannot extend the hip joint, so it will result in flexion. So this is called your flexion deformity. Now you have to quantify this flexion deformity. So to quantify this flexion deformity, you use what is called as Thomas test. So this particular patient, so whenever there is a patient with osteoarthritis of the hip joint, this will result in a flexion deformity. So to compensate the flexion deformity, the spine will produce excessive lumbar lordosis. The spine will produce lordosis, so it will increase its lordosis. So based upon this increase in the lordosis, the patient is able to manage his hip joint. So now what we do in this Thomas test is we first will try to decrease this lordosis. So we'll try to correct the lordosis so that we can see the flexion deformity in the hip joint, right? So how do we do this? So first we ask the patient to hard surface. So patient should lie on a hard surface. So first prerequisite is lying on the hard surface, and then the patient is asked to completely relax, and now you check for the lordosis. Now you check for the lumbar lordosis. So once you confirm that there is an exaggerated lumbar lordosis, and now you sound the limb. So that is the sound, or the normal limb is flexed. Normal limb is flexed, so flexion of this hip. So this flexion of hip is nothing but your thigh of that particular limb should touch the abdomen. So now you do the flexion of the limb, flexion of the hip of the normal limb. So when you do flexion of the normal limb, you will correct the lordosis, and you can feel that on your hand. Now before doing this correction, you will place your hand under the spine, that is for checking of the lumbar lordosis, and once you feel that lordosis is correct, that is the spine of the patient is touching your dorsum of the hand, that means the lordosis is corrected. Now you check for the flexion deformity. So this is the flexion deformity of the hip, and now corresponding to this bed, what is the flexion deformity? So the angle of that flexion to the bed or to the couch is called your flexion deformity. And now how do you measure this flexion deformity? You measured with your goniometer. So you use the goniometer for measuring this flexion deformity. So there are certain subtle points which you have to remember. So first, as I already said, you will check for the lumbar lordosis. So that will be the first one. So you will check for lumbar lordosis, and then you will flex the normal hip, right? So 1 and 5. So you will check, and then normal spine. So as you are flexing, you have placed the opposite hand under the spine, right? So when this spine is touching the dorsum of the your hand, you can see that the lordosis is done. Now you try to see that the pelvis is not tilted. So if you don't feel that touching of the spine, and if you exaggerate the hip, if you exaggerate the flexion of the hip, again now the spine will compensate it by tilting. Now the pelvis will tilt, and now your deformity, whatever flexion deformity, will be exaggerated. So to prevent that tilt, you will feel for the pelvis. So this is called the squaring of the pelvis. So you will prevent the pelvis tilt. So you will flex the limb, flex the normal hip, and you will feel for the loss of that lordosis, and then you will also check for the pelvis tilt. So for that, you put a eye on squaring of the pelvis. And now after your flexion and your squaring is done, sometimes this sound affected limb can go into more flexion deformity, right? So there you will ensure that the ischial tuberosity is touching the ground. So now the hip is touching the couch, and now you measure for the flexion deformity, right? So one is your exaggerated lumbar lordosis, that is one. Then you do flexion of the normal side, then you do squaring of the pelvis, then you ensure that you are not over exaggerating the deformity, and then you measure for the actual flexion deformity. So this is the answer for this, right? So these are the various steps which you have to follow in case of performing your Thomas test, right? So you have to remember that the pelvis should not be tilted, and you should not over exaggerate your flexion deformity, right? So for that you have to ensure that your ischial tuberosity is touching the couch. So that is the Thomas test. This Thomas test is done for your flexion deformity. So this is the flexion deformity which you see here, which you see in case of your this can be seen in case of avian, in case of tuberculosis. So whatever the pathology is happening in the hip joint will produce this flexion deformity. So after understanding this Thomas test, let us see what are the various tests which you can recall. So there is Thompson's test. If you can remember, the Thompson's test is for your Thompson's test. Yeah, that is what I'm doing now. So we are mentioning all the tests which are expected. So first we have done with Thomas test, and now we are discussing about the Thompson. Thompson test is for your tendo Achilles. Tendo Achilles. So you have to test for the integrity of the tendo Achilles. So that is your Thompson's test, and then you have, this is for your tendo Achilles. Then let us see some important test in case of your sports medicine. So here I will start first with the anterior Dryer's test for ACL. Then you have similarly the posterior Dryer's test for the PCL. And then you have your Latchman's test again for your ACL. Then your pivot shift test again for your ACL. So now coming to the Latchman's, this is considered to be the most sensitive test for ACL, and the pivot shift is considered to be the most specific test for ACL. So these two are the important tests for ACL, that is the anterior Dryer's, the posterior Dryer's for PCL, right? And for ACL you have Latchman's and the pivot shift. And then we have your McMurray's grinding test, that is for your meniscus. And then your valgus stress and the varus stress test. So these tests are for your collateral ligaments, So when you are giving your varus stress, you are testing for your medial collateral ligament, and when you are giving the valgus forces, you are testing for your lateral collateral ligament. So that is your collateral ligaments are tested for your varus and the valgus. So the collateral ligaments, and then that completes your knee test. Then we'll go to a shoulder where you have the empty can test. So the empty can test is for your supraspinatus. Supraspinatus tendon tear is the empty can test, and your belly press test. Belly press is for your subscapularis, right? So these are the important tests, and so these are the various tests which can be asked in the exam. So mainly these are related for your knee and the shoulder. So these are the important tests which you can remember, and this could be again asked as a one-liner. So there are various some 8 tests which we have discussed here, right? So this is the Thomas test, and then you can also remember there is a telescopy test again for your dislocation of hip. So you can move the hip femoral head outside and inside. This is called the telescopy test, usually seen in case of DDH. So developmental dysplasia of hip, in case of when they present it in the later ages, after the 1 year or 2 years of age, you will find this telescopy test. This is also test for your tuberculosis. And most important thing which I have forgot to tell you is the Trendelenburg test. So this was asked in the PYQ again. So this Trendelenburg test, it is for your abductor mechanism. So abductor mechanism is the Trendelenburg test. So in the hip joint again, you have two important muscles for the abductors. The abductor medius mainly will be tested by this your Trendelenburg test. So here what will happen, now the person, if he stands on two limbs, the pelvis will be straight. So you can see that this is assessed based upon your posterior superior iliac spine, PSIS, and if these two are at the same level, then it is a normal. And if there is an abductor weakness, just remember, whenever there is an abductor weakness, there will be a pelvis tilt. So whenever the pelvis is tilted on the right side, that means the abductor weakness is on the left side. That is the only thing which you have to remember. Pelvic tilt is there on the opposite side. The weakness is in the contralateral part. So if there is a pelvic tilt on the right side, that means the left side abductor medius is weakened or there is no strength. So there is a abductor mechanism failure on the left side, which will result in the right side tilt. So that is what you have to remember, the Trendelenburg test. So these are the various tests which you come across and you have to remember the important ones, right? And now coming to the next one. So this is about your peripheral nerve injury again. So there we have learned that there are three important nerves, the radial nerve, the medial nerve and the ulnar nerve. And here let us see what will happen if these nerves get damaged, right? So there is the peripheral nerve which you can remember. See, the peripheral nerve. So this is your peripheral nerve where there are parts of it. So this is called the cell body. Right, so this is the cell body and this is your axon and these are your axon terminals. Now here the axoplasm from cell body will flow along the axon and now they are dispersed over the axon terminals. Right, so they are dispersed upon axon terminals. And now based upon the injuries, there are three types of injuries which you have to remember. The first one is your neuropraxia. The second one is your axonotemesis. Third one is neurotemesis, right? So praxia is nothing but there is a loss of conduction only. There is no nerve injury. I mean, there is a nerve injury, but there is no damage to the part of the nerve. There is only loss of conduction, that is the flow of the axoplasm is blocked. So if you remember, I have told you that the axoplasm flows from the cell body to the axon terminals, right? So here the flow of the axoplasm is stopped because it could be any irritation. It could be a mechanical irritation, it could be a chemical irritation, it could be a dislocation which has been reduced after a longer time. So this causes the stretch of the nerve, and nerves are very sensitive to pressure and vibration. So whenever there is some abnormality happening around the nerve, you will see what is called as neuropraxia. So neuropraxia is that condition where the nerve is entirely intact but there is a block in the flow. So when the nerve is intact, you need not worry, right? So the recovery will be seen. So this recovery is 100%. So because only the nerve is intact and it will find its way, the axoplasm will find its way very at its pace, so that because the nerve is intact, it will flow, right? So this is 100% recovery is expected, and now this is at the rate of 1 mm per day. This also you have to remember, right? So the flow will start recovering, that is at a speed of 1 mm per day. The recovery is 1 mm per day. Right? So this is about neuropraxia. So when coming to axonotemesis, there is damage to the axon. So whenever there is damage to the axon, there will be a pathological process which is called as Wallerian degeneration. That means that because the axon is damaged, there will be the inflammatory process which is occurring there. There will be phagocytosis of the nerve. There will be regeneration of the new nerves. So this is all called as Wallerian degeneration. So whenever there is Wallerian degeneration, it will occur both in the proximal and the distal part. And this will take some time for the nerve, the axon to form again, and then the axoplasm should be flowing again. So the 100% recovery is not very much expected as neuropraxia, but there will be recovery. Right, so this is the axonotemesis. Neurotemesis, on the other hand, there is a break in the nerve. So when the nerve is broke, I mean that there is a damage to the layers, all the layers or the nerve itself is cut. So when it is cut, it will result in what is called as end neuroma. So this particular word is important, end neuroma, where this will not progress. So this will not progress and there is no recovery, and the patient requires additional treatment such as tendon transfers, additional neuron repairs, nerve repairs should be done. So these are treatments which is required for the patient. So you have to remember there are three important injuries, and this is called as the Sedan's classification. So this is your Sedan's classification. Why I have named as Sedan's? Because there is one more called as the Sunderland's classification. So it is called the Sunderland's classification. This is called the Sedan's classification. In case of Sunderland's, again you will see there are 5 types: 1, 2, 3, 4 and 5. Right, in the first one it is again similar to your neuropraxia, where there will be a flow block, that is your first one, and second one there is a damage to the axon, and from 3, 4 and 5 there will be damage to the endoneurium, the perineurium and the epineurium. Right, so these are the 3 layers of the nerve. This is from the physiology, if you remember the nerve anatomy. So this is the 3 layers which are covering. So axon is covered by endoneurium, and these endoneuriums are all placed in fascicles, which is covered by the peri, and the ultimate, all these bundles are covered by your epineurium. So Sunderland's classification is based upon this injury to the flow. First one similar to a neuropraxia, the second one again it is related to axonotmesis, and the third one is divided into layers based upon the epi, peri and the endo. It is divided into 3, 4 and 5. So in this 3, 4 and 5 there will be cross innervations because there is a damage. So there is a substance which is damaged there. So there will be cross innervations and the recovery is not as expected. But in case of neuropraxia and axonotmesis, the recovery is good, right, compared to the neurotmesis. So this is about the nerve injuries, and this will make your answer easy. So the axon sheath will be intact and the nerve fibers will be damaged. So that means it is nothing but your neuropraxia. Right, whenever the axon sheath is intact, it is neuropraxia. That is only the flow is it is only the flow which is disturbed here, and if it is the nerve fibers which is damaged and there is axon sheath which is damaged, then it is axonotmesis. Right, if the axon sheath is intact, it is usually the neuropraxia. Right. So coming to the Sunderland's, then this could be the third one. So axon sheath is intact, the axon fiber is damaged, this could be a second one, right? So axon sheath is, if they are considering the axon sheath as the endoneurium, right? Axon sheath is considered as endoneurium. So endoneurium is intact, there is damage to the nerve fibers, it is Sunderland's type 2, and Sunderland type 2 is related to axonotmesis here. So that is about the question. So that is the 10th question we have completed, and then we have seen this, the 11th one. So match the following conditions with the correct management. So this is again about the tumorous condition, right? So in this case, what are the tumors which are given are the CBC, that is a simple bone cyst, the osteoid osteoma, GCT and osteosarcoma. If you don't know anything about this question, just remember that osteosarcoma is malignant. So it should be treated aggressively, right? So in all these, the aggressive one is wide excision. So look for D and 1. So there are 2 options which are there for D and 1. And if you remember, the osteoid osteoma is treated with the radio frequency ablation. So that is B, and B is 3. Okay, here. And SBC, the simple bone cyst, is treated with steroids, and GCT, if you remember, is treated with the curettage. So curettage C is 4. So C4 is the only one option. So if you know that giant cell tumor is treated with curettage, you can directly answer this question. So here, if you see the simple bone cyst and the osteoid osteoma, these are the benign conditions. So benign, and you have intermediate type, and then you have your malignant type. right? So here there is a benign type, that is your simple bone cyst or the osteoid osteoma. So these two can be treated with a simpler procedure. So osteoid osteoma is radiofrequency, simple bone cyst you're giving intralesional steroids. Intermediate such as your GCT is intermediate where you required curettage. So you required excision, you will remove, and then you required curettage. So that curettage is again an extended curettage where you use phenol or liquid nitrogen to treat it. So this is extended curettage in case of intermediate type, and malignant type is always starts with wide excision and then it can go up to your radical excision. And then they can be followed by your chemo or your radiotherapy. So these are chemo and radiotherapy with the excision is usually treatment for your malignant conditions, and benign usually they treat with extended curettage, mainly the GCT, which is treated with liquid phenol or the phenol or liquid nitrogen. And then there is a benign, that is SBC and the osteoid osteoma, treated with a minor treatment such as your radiofrequency ablation, that is the local area you put, and then your intralesional steroids. So that is the treatment for your tumors. And now you have to remember that there is a adjuvant chemotherapy and neoadjuvant chemotherapy. This can again be an integrated question. So neoadjuvant chemotherapy is one which is given before the surgery. So this was recently asked in the PG, NEET PG examination recently. So neoadjuvant chemotherapy is one which is given before the surgery, and this is mostly given for your downstaging and downgrading the tumor. So you will decrease the stages and the grades of the tumor so that the bulk of the tumor is decreased, and now you can remove only a little part of the tumor. So when you debulk the tumor, the loss of the bone to the patient is less, right? So hence this neoadjuvant is playing an important role, and adjuvant is given after the surgery. If there is a metastasis, if there is a positive margins, then you go for your adjuvant chemotherapy. So that is about the treatment of the tumors. Now let's see, this is again important peripheral nerve injury bit, and you have already know that this is nothing but your partial claw hand, and this is the ulnar area, right? So this is the ulnar part. And here the nerve which is involved is your ulnar nerve. So this is the partial claw hand, mainly ulnar nerve, where you see the complete claw hand. Complete claw hand is seen in ulnar plus median nerve. So ulnar plus median nerve is your complete clawing of the hand, and here you see the partial clawing, the little and the ring finger are flexed, the MCP are extended. So this is the claw hand. Right. So now let us discuss some of the important tests which have not done in the peripheral nerve part. So here if you see, this can be IBQs. So this is the one important one. This is called the book test or the Fromen's sign. So what is this test? So book test, you are asking the patient to hold the book, and in this particular hand he is holding the book properly, and here he is adducting the thumb. So he is using the adductor pollicis, right? And here if you see, he is holding the thumb with the flexion of the IP joint. So this here because of the adductor pollicis palsi. If you remember, the adductor pollicis is supplied by your ulnar nerve, right? So in case of ulnar nerve palsy, you see what is called the book test. So this is the book test, right? And here you can see the flexion of the thumb. This is called as the Fromen's sign. So this flexion of the thumb is called the Fromen's sign. So F for F, flexion, Fromen's sign. It is seen in your ulnar nerve palsy, because you have to remember that the adductor pollicis is supplied by the ulnar nerve. Now the patient is using the median nerve for holding the book. And now this is your pen test. So again you are abducting the thumb. So abductor pollicis. So if you remember, pollicis is for thenar, and thenar group is muscle is supplied by the median nerve. So here the pen test is for median nerve, the book test is for the ulnar nerve, and the third one here is your adduction. So holding this particular piece of paper or card in between the fingers that is by your adduction, right? You adduct two fingers and hold it, and now the examiner tries to pull it. So if the adduction is perfect and if you're holding the card or paper, this is called the card test, and it is again testing of the adductor is by your dorsal interossei and palmar interossei. So palmar interossei called the adduction, so you remember it as dab and pad. So dorsal for abduction, palmar for adduction, and these two are supplied by your ulnar nerve. So card test, we have checked for your palmar interossei, and there is Igawa test is for your dorsal interossei or your abduction. So these are the various tests you should perform for the patient complaining of ulnar nerve palsies. So there is a card test, there is a Igawa and the book test, right? And then the pen test for the median nerve, right? So one more sign which you have to remember for me, Kilo-Nevin sign or your OK sign is again for your median nerve and especially for your anterior interosseous nerve. So Kilo-Nevin sign or the OK sign which you put, where you ask the patient to tell, okay, this is the complete, okay, the perfect round. If you see, this is the test for your anterior interosseous, and when there is a palsy, you see what is called as decrease in your O or the OK sign, right? So that is your Kilo-Nevin sign for median nerve palsy again, and the wrist drop for your radial nerve palsy. So whenever there is a radial nerve palsy, the patient presents with the wrist drop, and finger drop is seen in case of your posterior interosseous nerve palsy. So in case of posterior interosseous nerve palsy, you see the finger drop, right? So these are the various tests again you will see in case of your peripheral nerves. So peripheral nerve injury is a very important topic where you can expect questions. So at least you will get 1 or 2 questions from the peripheral nerve part. It could be the blood supply, or it could be the test which are involved, or it could be the treatments or imaged based questions. So these are the splints which you used in case of your palsy. So whenever there is a palsy such as your radial nerve palsy or your ulnar nerve palsy, so you use splints. So why? Because there is a no nerve supply, this tendons will go into contractures, right? The tendons will become supple. So to maintain the tone of the tendons, you put them in the functional positions in case of your palsies, right? So for that you use the splints. So whenever the important one here is your radial nerve and the ulnar nerve, so in case of radial nerve, you use the cock-up splint. So this is called the cock-up splint, where you do the extension with the help of the splint. And if you're actively doing the extension with the help of the splint, this is called the dynamic. Or if you're just resting in extension position, that is called the static. So here in this case, this is your dynamic cock-up splint. So this is your dynamic cock-up splint, right? So here you can see the springs, and there you cause the extension of the fingers. And this is your VIC or your Workman's splint. So this is the Workman's splint, where you see in case of your VIC, that is Workman's ischemic contractures, where you will find the contractures of the flexors here, and you will gradually extend them, preventing the contractures. So this is your Workman's splint, and this is your dynamic cock-up splint. So this was recently asked in the NEET PG, so I have put the two images together so that you can have the idea of what is dynamic cock-up splint and what is your Workman's splint. So Workman's splint is here you put the complete brace is applied to the forearm, so that the contractures are this flexion or extension is done again the wrist joint. So right, so here because of these contractures, the tendons will get contracted like this, and now you have to when you extend, they will become extended. So when you flex the wrist, they become extended, and when you extend it, they become flex. So this is your Workman's sign, right? So this is your Workman's sign because of the contractures. So here in the Workman's splint, what you do a graded relaxation of that contractures. So this is called the Workman's splint or turnbuckle splints. So turnbuckle splints can be used in anywhere of any joints in case of contractures where you want to gradually extend the tendons. And in case of cock-up splint, what you do is the wrist drop. The wrist is dropped down because of the radial nerve palsy, and now you try to extend the wrist and the fingers, right? So you are doing this extension and the extension of the fingers and the wrist. So this is help of the springs which are present on the dorsal aspect. So this is called the dynamic cock-up splint. So that is about the peripheral nerve injuries with their splints. And next, in the patient with the compartment syndrome. So this is a straightforward question where the very important topic, that is your compartment syndrome, you all very well know that is this is the complication of the fracture where there will be a rise in the pressure of the compartment. So if you remember, the limbs are divided into various compartments. So there will be rise in the pressure of the compartment will cause what is called the ischemia of the muscles. So why there is ischemia of the muscles? Because there is an increase in the pressure, the blood flow, usually pressure gradient. So the flow of any fluids is across the pressure gradients, right? So whenever there is an increase in the pressure, there will be no flow of the blood to the compartment. But whenever there is no flow to the blood, there is an ischemic process. This ischemia is a pathological process which will again increase the edema, right? So this edema will again increase the pressure, and again there will be decreased blood flow, again ischemia, again edema. So this is a vicious cycle which occurs in the compartment. Why? Because of the tight fascia. So there is no break for this cycle because it is going in the very closed circuit. So there is no opening for it to go or burst. So it is what the pressure has been built up again, this closed volume, right? So this high pressures will cause damage of the muscles. So this will first produce what is called as a pain on stretch. So whenever you try to stretch the muscles, because already the muscles have been compromised with the blood supply, when you try to stretch them, they can't act, and then they produce a severe pain. And if this pain is not proportionate, and if the patient is asking for increased dose of analgesia than the normal, then you have to always think of compartment syndrome. So first is the pain on stretch, and what is the last? Here the question is last. So last is the paralysis. So paralysis. So first there will be, so there are usually they say there are the 5 signs, so pallor, pain, paresthesias, and then there is pain with the paralysis. So finally it will end in paralysis. So the last to occur is your paralysis. The first one is pain on passive. Yes, the pressure gradient, if it is more than 30 mm of Hg, that is confirming for your compartment syndrome. So what is the treatment? So this is an emergency. Treatment is your fasciotomy. So always remember to have to do the fasciotomy, and you have to release all the compartments in the particular limb. You have to check for all the compartments, right? So this fasciotomy is an emergency procedure which you have to do for the compartment syndrome. And the last thing to occur is the paralysis. The first one is pain on stretch, and pulselessness is not immediate. It is also a late sign. So usually we think that because of the decreased blood flow, there will be decrease in the pulse. So if pulse is present, you can rule out compartment syndrome. No, that is not the thing. Pulselessness is also a late feature. So first is always pain and suspicion. And please remember that the compartment syndrome is mainly based upon your clinical knowledge, right? This is a clinical thing which you have to diagnose, and you have to be well versed with the procedure that we have to do at a greater speed to protect your muscles. So that is the fasciotomy. So now the next question is about the deformity and the name of the fracture and the pathology which leads to this deformity. So if you see this deformity, it is very easy and very commonly seen in case of children, and this deformity is nothing but your cubitus varus deformity. So how did I tell it as varus? Because the distal is coming towards the midline. So whenever the distal part is coming towards the midline, this is varus, and when it's going away, it is valgus. So cubitus varus deformity, this varus deformity in case of elbow is mainly seen in which condition? It is seen in your supracondylar fracture humerus. So there is supracondylar fracture humerus, and this usually goes to malunion, where they will be united fracture. The fracture union will be there, but the alignment is abnormal. So that is called the malalignment, and this malunion will result in the cubitus varus deformity. And to the contrary, there is the intercondylar fracture, or the called as the lateral condyle fracture of the humerus. So in this lateral condyle fracture, because this is an intra-articular fracture, so the problem here will be the non-union. So there will be a non-union of the fracture, and this will result in cubitus valgus. And what is that important complication you see in cubitus valgus? Pihu, you're talking about which one? Pulselessness is seen as a late feature, but the last is paralysis. Pulselessness is seen as a late feature in case of compartment syndrome, but the last one is your paralysis. Here the question asked was the last one, so it is paralysis, right? And coming to this particular topic, so the supracondylar, you have to always remember that the supracondylar will go into malunion because the union will be there, but if it is not fixed properly, if the fracture treatment is not done appropriately, it will go into cubitus varus deformity. And in case of intercondylar fracture of the humerus, it is an intra-articular fracture, hence it is prone for non-union usually. So in lateral condylar fractures, you see non-union, and this will result in cubitus valgus, and this cubitus valgus will result in an important complication, that is your tardy ulnar nerve palsy. So there is a tardy ulnar nerve palsy, right? So this is the complication which we expect in a patient with a lateral condylar fracture humerus. And gunstock deformity, that is the malunion or the cubitus varus deformity. This is the gunstock deformity. So this is the gunstock deformity which we are talking about, and this is cubitus varus, supracondylar and malunion. So this is the answer, right? So this is the combination which the examiner was asking about, right? So that completes the fracture around the elbow. So what is non-union? Non-union is nothing but the fracture will not unite, and for this union to occur, you need an intervention. The surgical intervention is required. So what is that surgical intervention? You can do a fixation. So when there is a mechanical problem, so if the fracture is not fixed properly, you have to support it with more stability. Or if there is a biological problem, that is if the bone is not sufficient for regrowth of the cells, then you have to put bone grafting, right? So you support it and then you take it to union. So this is non-union, and malunion is union has already occurred, but it has not occurred as we expected. So there is a malalignment, or there is some deformity which is occurring there. So that is the malunion. Right. So this is again a cakewalk question for you. So during clinical examination, patient was unable to flex his distal interpharyngeal joints in 4th and 5th. So that is DIP. So DIP is by FDP. So flexor digitorum profundus is the problem. And here he is talking about the paper or the cart test, who is unable to hold. So the answer is straight away ulnar nerve. Right. So this is we have already discussed so much about the ulnar nerve. So the answer is the ulnar nerve. Right. And next, coming to some of the important named fractures. So there are a tendency for asking of this named fractures. So here I think you have to just remember the names. So let me make it simple for you. The March fracture is nothing but a stress fracture. So usually seen in the metatarsals. So the second metatarsal is your March fracture, right? Boxes is your 5th metacarpal. So when a fixed fist is used and you hit it over the wall or hit it like during boxing, that the boxes fracture. So the 5th metacarpal is the boxes fracture. So let's make a D for B, right, and B for D. And then you have your Jones fracture. This is again the fracture of the 5th metatarsal. You have to remember the Jones fracture is the 5th metatarsal base. 5th metatarsal base is the Jones fracture. Boxer's fracture is metacarpal. Boxer's is metacarpal. And you remember the Bennett's and the Rolando. So Bennett's and Rolando is mainly for your first metacarpal. So first MCP joints which were involved are called the Bennett's and the Rolando. The Bennett's and the Rolando, in case of Rolando, it is Y-shaped, right? Both are intraarticular fractures, but the Bennett's has its dislocations which are specific and it requires treatment. It requires a proper treatment for it to unite. Rolando is somewhat like the comminuted fracture, right? So there are multiple displacements in it, but Bennett's is one which you require proper reduction of it because of the pull of the fragments based upon the muscles which is attached to it. So because of this pull, you need to appropriately reduce it. So you have to reduce it and then fix it with the K-wires. So then we have completed it. So the Bennett's is your first metacarpal. So C for A. So A is C, right? So A is C, D is B, B is D, and then the last one, Jones fracture, that is A is for your C. Right? So that is the various eponyms of the fractures, and then you have your Monteggia, and then you have your Galeazzi fracture. Right? So these are also some of the named fractures, and then you have your Pott's fracture, then your Cotton's fracture. So there were names which are there. So this is, what is that? Ulnar, na? Ulnar 4th and 5th DIP. Yeah, that is what Ulnar is 4th and 5th DIP. So now coming to the Monteggia's and Galeazzi's. Monteggia fracture is the fracture of the ulna with the proximal radio-ulnar joint. So remember M for medial, that is the ulna, and proximal radio-ulnar joint, right? Right, and then Galeazzi is fracture of radius with distal radio-ulnar joint. Right, please remember the Monteggia is the ulnar fracture with proximal radio-ulnar joint dislocations. Radio-ulnar joint dislocation, that is nothing but your radial head, mainly the radial head dislocation. So radial head is dislocated with fracture of ulna is called the Monteggia, and Galeazzi fracture of the radius and with distal radio-ulnar dislocation. So this is the fracture of Monteggia and Galeazzi. And Pott's and Cotton's is seen in case of ankle, where Pott's is called the bimalleolar fracture and Cotton is called the trimalleolar fracture. Right? So this again you have to remember. So there were various eponyms of the fracture. So some of the important one is Monteggia and Galeazzi. Usually they are asked in the exam. And what is a green stick fracture? Green stick fracture is an incomplete fracture. Incomplete fracture where you see bend in cortex. So one cortex is bent and break in other cortex. So there is bend in one cortex, break in other cortex. It's a type of incomplete fracture which is called the green stick fractures, right? So these are the certain important fracture names. And then we are coming to the metabolic diseases where the patient here is diagnosed with osteoporosis. Which of the following can be expected in this patient? So if you remember the osteoporosis, so the osteoporosis is a qualitative defect, right? Sorry, it is a quantitative defect. So there will be a problem. So if you see this as your normal bone, so here there will be osteoid and this is your mineral, right? And in case of vitamin D deficiencies, so here the mineral will be completely reduced. Same proportion, but the mineral will be completely, this is the mineral portion which is less and this is the osteoid which is more. Hence the bones become weak, right? They can be easily deformed because the mineral is one which gives the strength to the bone. Now the mineral is decreased, hence they become weak, and what is called as rickets in children and osteomalacia in adults, right? Now when you come to osteoporosis, here whatever the complete is decreased, so complete the bone strength, the bone density itself is decreased, where the mineral is normal, the osteoid is normal, so both are normal, right? So this is again the mineral and the osteoid. So if this is 2:2 ratio, this becomes 1:1 ratio, right? So both is decreased and the bone becomes weak, the bone density is weak first in this osteoporosis. So this is osteoporosis, where you see everything in normal, that is normal calcium and normal alkaline phosphatase. That means the patient is suffering with the decreased bone mineral density. So the amount whatever is present, the mineral and the bone osteoid, both have been decreased, but the ratio is the same. So here this is called the osteoporosis, right? So in case of osteoporosis, it is mainly bone mineral density which is decreased, and usually it is seen in case of vertebrae, and the patient mainly seen in case of the post-menopausal woman. So osteoporosis is a degenerative type of disease where you see in older people, mainly the post-menopausal women are at risk. So this is the osteoporosis, where all the parameters such as the calcium and the alkaline phosphatase will be normal, and sometimes you can see there will be a slight decrease in the calcium or the vitamin D, but not as low as in case of vitamin D deficiencies, right? And that is the osteoporosis. And now next is the 42-year-old female. There was a morning stiffness along with the pain in the smaller joints of both the hands. So if you remember in the first slide what I told you about the inflammatory arthritis, these are mainly seen in case of hands, right? And the smaller joints, that is the hand joints, are involved, and here this is female. So autoimmune diseases are more common in case of females, and the inflammatory diseases are mainly seen in case of females, and morning stiffness. So when I say degenerative type of disease or osteoarthritis, they are usually seen at the end of the day. So as the patient uses the joint, as the day progresses, the pain increases. But in case of inflammatory is you are putting the joint at rest, and then now the pannus will act at a more speed. So when at rest the pannus acts more, there will be a lot of damage to synovium and there will be swelling of the joints. So soon after the rest, that is the whole night the patient is at rest, and usually early morning, that is morning stiffness, is seen, and mainly in case of hands, that are the smaller joints, and mainly your PIP and the MCP joints are involved, and this is nothing but your rheumatoid arthritis, right? Rheumatoid arthritis is one such disease which is mainly seen in females. Morning stiffness, hands, smaller joints, all put together is your rheumatoid arthritis. So what is your Reiter syndrome? It is a triad where you see arthritis with conjunctivitis and urethritis. So this is a triad you see in case of reactive or Reiter's syndrome, and usually it is thought to be by chlamydia and now shifted to E. coli and salmonella. So these two are the bacteria. So soon after the infection of this bacteria, it might be because of this conjunctivitis and the urethritis and then the arthritis. These three combination is nothing but your Reiter syndrome. Ankylosing we have already dealt with. Lupus is your SLE, right? And now again one more from the osteoporosis. So in case of osteoporosis, which of the following investigations can be used for diagnosis? So you already know that is the bone mineral density which is at the risk, and this can be detected by your DEXA scan, dual energy X-ray absorptiometry, where you use low intensity X-rays and you take the information mainly from the calcaneum or the vertebrae, and now you do what is called as a Z and the T scores, right? So Z and the T scores are done, and whenever this T score is less than 2.5, standard deviations less than 2.5, it is called as osteoporosis, right? So the DEXA scan is used, right? And then X-ray is very much used, because X-ray is the first investigation to use for osteoporosis, where you see the decrease in the density, right? So that is the X-ray is most used, and then you do quantitative CT. So this CT scan analysis is done to see the amount of osteoporosis, right? If what is the stage, whether it is mild, moderate or severe, you take the CT scan of the vertebrae and you measure the vertebral columns, right? You measure the vertebral height and then you compare it with the normal. There are various tools which are available which take in account the patient risk factors and your mineral densities, which is called as FRAX. So this is the tool which is used, and this is done by your CT scans. So you use the DEXA, your quantitative CT, and then your X-rays, and finally you also use the chemical analysis to rule out the levels of calcium, to rule out the levels of vitamin D and alkaline phosphatase, all this to work up for your secondary osteoporosis. So this could be because of hyperparathyroidism, it could be of various conditions where you see a decrease in the bone mineral density, right? So these 4 things which you have to be done for the osteoporosis, and once you claim the patient as osteoporosis, so you start with treatment mainly first with calcium and vitamin D, and then the first line treatment for your osteoporosis is bisphosphonates. So bisphosphonates are the drug of choice mainly for the post-menopausal osteoporosis, right? So there are various drugs which are available. So alendronate, ibandronate, zolendronate, these are the drugs. So alendronate is most commonly used. So first is the bisphosphonates, then you use the denosumab. So denosumab is RANKL inhibitor. So whenever the RANKL ligand is inhibited, it will decrease the osteoclastic resorption, right? So denosumab, and finally you treat with parathyroid. So this parathyroid hormone, it is the teriparatide which is used, and teriparatide, this is given in the low doses, which will increase the bone formation. And ultimately you have your strontium pronolate. So this increases the formation and decreases the resorption. So here these two will decrease the resorption, the bisphosphonates and denosumab. The parathyroid will increase the bone formation, and strontium pronolate will do this, both the things. It will decrease the resorption and increase the formation. So this is the treatment for the osteoporosis. So first you start with the bisphosphonate, then you go with denosumab, and finally with the parathyroid, right? So this is the treatment for osteoporosis, and the investigations, you start with the X-ray first, and then you go for DEXA, and third one is a CT, and finally you do the chemical analysis to rule out all other conditions. Bone scan you use for identifying, for the metastasis or for the infection, right? So you use the bone scan where there are various arterial phase, where there is the various phases you see. So whenever there is an increase in uptake in the bone scan, that means there is osteoblastic activity. When there is a decrease in the bone scan, the decrease in the uptake in the case of bone scan, that means there is a lysis which is occurring there. So bone scan is mainly for the tumors condition. So metastases and infections, to rule out, you go for a bone scan, right? Okay, then in this image, which of the following braces have been depicted? So there is a Taylor's, Ash, Boston, Milwaukee brace. So if you remember, just remember one important condition, that is the scoliosis. So scoliosis, there are 2 important braces which you use, the Milwaukee and the Boston brace. So Milwaukee. So before understanding these braces, let me give a brief introduction of what is orthosis. So when I say orthosis, that means that it is the it is a product, or which is a thing which is supporting your body. So whatever part is supported, you name that orthosis. So if you are supporting the lumbar spine, you name this as lumbar orthosis. If you are supporting the thoracic spine, you name this thoracic. If you are supporting the cervical, you name this as cervical. So cervical, lumbar, thoracic, sacral. So your Milwaukee is all these 4. So it is a cervical, thoracic, cervical, thoracic, lumbar, sacral orthosis, right? So this is the Milwaukee brace. So directly from the cervical spine to sacral spine, this is used, and this is mainly used for scoliosis, where you see the curves in the upper areas, right? In case of higher thoracic and your cervical. So remember, Milwaukee is starting from the cervix to cervical region to your sacral region, right? So cervical then your thoracic, then your lumbar, then your sacral. Coming to the Boston brace, Boston is mainly from the thorax. So thorax, lumbar, sacral. So there is no cervical part which is supported in the Boston brace, and Boston brace is prefabricated material, right? So these are some of the braces. So we have already understood. So this is your Milwaukee brace. So the answer for this is your Milwaukee brace because it is cervical, thoracic, lumbar and sacral, right? And what is Boston's? So this is your Boston's brace. So this is a prefabricated brace where it's supposed from the thoracic, lumbar and the sacral. So orthosis, this is also used in case of scoliosis, and here usually the curve starts somewhere around T8, right? So whenever the curve, the apex vertebra is around T7, T8, then you can use this Boston's brace. But when the curvature, when you're treating the scoliosis of the upper curves, such as in your upper thoracic curve or your cervical curves. So scoliosis is nothing but sideward bending, right? There is a curvature, sideward curvatures which you see in the spine. So these higher curves are treated with your Milwaukee, this lower are treated with your Boston. And what is this? This is very, very important, and you regularly see if you are completed your internship. So this is your Taylor's brace. So Taylor's brace will again support the thoracic and lumbar region, right, in the thoracolumbar areas, where you can give them for your fractures, your osteoporosis, for the support, and mainly you have to remember it is given in your TB spine. So we have read the middle path regime there. So in there we are resting the patient, we are resting the part, that is with your Taylor's splint, right? So this is your Taylor's brace. And then this is your Ash brace. So what is Ash? Anterior spinal hyperextension. So this is particular Ash brace which is used for treating the kyphosis in case of osteoporosis. So in case of osteoporosis, you mainly get kyphosis, or you can go for vertebral fractures. So whenever there is vertebral fractures, you go for vertebral fractures associated with osteoporosis, you go for Taylor's brace. That fractures are mainly seen in the lumbar areas or dorsal areas. But whenever there is a forward bending, forward curvature of the spine in case of kyphosis, you treat with this Ash brace. So anterior spinal hyperextension brace. So these are certain orthoses which you have to remember, and most commonly asked is your Milwaukee brace. So recently they have asked Milwaukee's. There are high chances for asking for Boston's now. So this is the Boston's brace. So put this image in your head so that you can answer it easily, right? And now this is the last question. So what is this question is about? So I think this you can easily answer because we have already completed this. So here there is a 12-year-old child presented with orthopedic OPD with the pain around the knee joint. So this is the knee x-ray which they have given to us, right? And there they revealed a lesion in the distal part which extending up to the end, and the x-ray is taken below. What would be the diagnosis? So here if you can just see this lesion, whatever is there, it is mainly near the metaphysis region. So metaphysis region, and you can see there are some extensions. So this is called the sun ray appearance. The sun ray appearance with the metaphyseal region, right? And the age is 12 years old, male child. So mainly it should be your osteosarcoma, right? So in case of osteosarcoma, mainly you see in the metaphyseal region, and osteoid osteoma you mainly see in the diaphyseal region. Chondroblastoma is again in the epiphysis, and giant cell tumor is again in the epiphysis. So this is the metaphysis, right? So this is the osteosarcoma, right? And you can see the sun ray appearance here, right? So this is the thing. And here I want to complete this session with a very important question always. So a very important question, that is your giant cell tumor. So let's end the session with the giant cell tumor. So this is also called as the osteoclastoma. So if you remember that the soap bubble appearance is seen in this condition. And one more peculiar feature is that it is seen in the epiphysis region. and this is characteristically described as encroaching onto the joint. So you can see such that the tumor is very aggressive tumor. So this is the aggressive type of tumor. So what is the aggression? That is, there is always a recurrence of the tumor. And you will see the giant cells on the your pathological slides. So yeah, so this is the distal radius area usually seen, right? But the most common area is again the knee joint, right? So the most common site where is seen is the knee joint, but here you see the distal radius. So giant cell tumor where it is going up to the joint here, so the joint is involved and there is a soap bubble appearance, the giant cell tumor. And what are the most important things is you can see the faint lines there, so that is the soap bubble appearance. So these are all the characteristics. And one more important thing is it is expansile in nature. Expansile, epiphysis, eggshell cracking, all these are peculiar for your soap bubble, right? Yeah, it is aggressive locally, no metastasis. It is aggressive but only locally. Very good, right? So that is your giant cell tumor. And finally, I want to just put this is your ABC. So this is your aneurysmal bone cyst. This is also expansile, right? So this is also expansile, but the difference is it is at the metaphysis region. So metaphysis, so that is at the epiphysis region, right? And here if you see, there are the density levels which you can see. So fluid filled density levels. So these are all the on the MRI. If you see, there are intralesional fluid fill levels are seen. So these are the levels. So this is the MRI of the ABC, that is the aneurysmal bone cyst, and this is the X-ray. So that is the difference between your GCT and ABC. Both look alike. So this is metaphysis. You have to be very careful and look for extra points which you can mark towards your ABC, right? So these are the things which we have condensed from your previous year questions and brought it as the short series. Hope you all have understood, and this might be helpful for you just as a basic revision before going to the exam. Thank you for your patient listening, and there is a grand test which has been conducted for you all on 30th April, 1st May and the 2nd May. So you all can attend this grand test and make a maximum profit of this, because it has been taken from all the previous year's questions, and we mainly concentrated on the important topics. So this could really help you, and please attend this test, and all the best for your exam. And finally, a very big thank you for this opportunity.